Dear colleagues, this is a hard intumescent cataract with small pupil. Let us watch the surgical steps. This is the main incision. It is a 2.8 millimeter main incision. And now this is a stab incision at 7 o'clock. In this case, I have planned to use iris hooks. That's why the stab incision is here. Now air bubble has been injected into the antechamber, and now I am injecting some adrenaline. This is preservative free adrenaline, and the pupil has dilated a little bit, but it is not enough. I am not satisfied with this size of pupil to go without some pupil dilating device. I've stained the anterior capsule with trypan blue dye, and I wash the dye out of the anterior chamber. And now I'm going to inject some viscoelastic substance. Here it is. This is 2% hydroxypropyl methyl cellulose. And now some more stab incisions. This is a stab incision at 10 o'clock. This is another stab incision at 1 o'clock. This is a stab incision at 4 o'clock, and this is a stab incision at 2:30 o'clock for introduction of chopper. Other stab incisions are for introduction of iris hooks. And now these are the iris hooks. This is the first one being applied at 7 o'clock. This is very easy to apply. Just retract the silicone guard, hook the iris margin. You may have to take some attempts to hook the iris margin and then gently pull the iris. This is the second hook at 1 o'clock. This is the third hook at 4 o'clock, and this is the final hook, fourth one, at 10 o'clock. So in this case I have used 4 iris hooks. Now I'm going to incise the anterior capsule with a 26 gauge bend needle and see what has happened. Oily fluid has come out. It indicates increased ILP. ILP means intralenticular pressure. So whenever you make a puncture on the anterior capsule, whenever some oily fluid or something comes out, it means there is high ILP. And in such cases I always do a twistis-rhexis. The small one has been made, and now I am going to remove some cortical matter from the cataract so that intralenticular pressure decreases. So I irrigated the capsular bag through this small rhexis opening, and intralenticular pressure has reduced drastically. Now I inject viscoelastic substance, that is HPMC. Take a Vanna scissor and the margin of this mini rexis. Here the cut is at around 8:30 o'clock. I hold this capsular tag with Utata and enlarge this rexis to an optimum sized one. So the rexis has been enlarged to an optimum sized one, and now I enter into the antechamber with the tip of the phaco handpiece. The tip must be introduced with its bevel down and then rotated to make the bevel up. And in this case, I'm doing direct chop. I just bury the tip in the substance of the nucleus, hold the nucleus firmly and chop it. Here it is. Hold it very firmly and chop. So this is very easy. Once you just start, you'll enjoy cataract surgery. You'll enjoy phaco so much. And direct chop you have to learn, because whenever the pupil is small, you cannot do divide and conquer in such cases. You can, but it takes longer time and lot of ultrasonic energy you have to impart inside the antechamber, which can cause endothelial cell loss. That's it. The nucleus has been removed, but there is a very small nuclear fragment. A very small bit is there. You can see it. So we must remove this nuclear fragment first. Here it is. Before removing the cortical substance, we must remove any small nuclear fragment. Otherwise, it can get lost underneath the iris, and after 1 month, the patient can come with corneal edema inferiorly at around 6 o'clock. And that is very ugly to look at. So always remove any nuclear fragment that you see before removing the cortical matter. Dear colleagues, why am I making so many videos? It's not to show that I can do this and I can do that. This is just to encourage you that you can do better than what I can. Just you have to bring a balance, you have to bring stability, you have to bring some skill in your hands. It is there. You just have to bring it. You just have to train your hands and make it safe for the eyes of the patients. After removing the iris hook at 1 o'clock, I inject the IOL in the capsular bag. Why I removed the hook? Because if I remove that hook, the iris falls back, and while injecting the IOL, I will not cause any severe push on the iris, and thus I will not cause iridodialysis. Now I remove the other hooks. It is so easy to remove. Just retract the silicone guard, advance the hook, unhook the pupillary margin, and remove it like this. So after removing the hooks, this is the last hook to be removed. Retract the silicone guard, advance the hook, unhook the pupillary margin and remove the hook. And now I remove viscoelastic substance from anterior chamber. I go behind the IOL and remove the viscoelastic substance from the capsular bag. Don't be afraid of rupturing the capsular bag with this gentle fluid flow. Never it has happened. I have done about 50,000 surgeries by this time, and out of that about 30,000 will be phaco surgeries. And never posterior capsule has ruptured because of this fluid flow. So that's it. Just hydrate the side port which I have used for introduction of chopper. Other small stab incisions doesn't need any hydration. That's it. The case is done. Anterior chamber is formed. Hope this video will help you in developing your skills. Be a great surgeon, my friend.